So we're going to do, as Fred said, there are many different dimensions to precision or precision health, and I'm going to talk really about the genomic aspects since I'm and the inherited aspects since I'm a medical geneticist. Just in terms of disclosures, I am on the SAB for the Regeneron Genetics Center, and one of the studies I'm going to show you about today was funded by Biogen. So as we've been thinking about this is something that certainly the public has been thinking about in terms of genomic medicine for a long time. And I always like to set the context in terms of what realistically we can do, because I think there's a lot of increased expectations. As you can see, we've been thinking about this really for a long time. And this is something that comes up over and over again in terms of the media and what they say we can do and what we really can, in practicality, do and do effectively. So there are really two ways that I think about this. As we think about precision health, to me, that means keeping people healthy. They start out healthy and we keep them healthy, and that's certainly an important part of what we need to do. But there are also people who come into us in the office or in the hospital who are already sick, and trying to figure out for them what is really their diagnosis, what's the best way to get them healthy again is the other half that we think about this. And I'm going to try and take you through a bit of a whirlwind tour in terms of various different clinical areas of medicine. You're going to hear this morning in a deeper way about certain specific aspects, but I'm going to try and give you an overview and try and show you the places where I think we actually are in the trenches doing a lot of this and how incredible it is, how we've scaled this. Also some of what the challenges are, and there is a big challenge in terms of payers really believing that this is effective in terms of being able to improve health. And I think we do need to be more rigorous about getting the evidence together as a community to actually demonstrate the efficacy of this. So as we're talking about this, I'm going to start out first with individuals who are sick. And for those individuals who are sick, being able to understand why they're sick and at a molecular basis understand what the best treatment for them is going to be is a lot of what takes my energy. I can tell you, because we've run programs for individuals who've been searching for a diagnosis, my record is someone searching for a diagnosis for 25 years that we finally solved with new methods of genomics. It can be an incredibly expensive, time-consuming, frustrating process with many missed opportunities, unfortunately, and in some cases, actually giving treatments that are counterproductive when we're not dealing with we're actually treating the right condition. With all of this is certainly helpful to treat that individual as well as to do what I call cascade testing and inform other family members who may be at risk for certain conditions or help to make reproductive decisions, especially for parents with small children who are affected with these conditions. In addition, in a cosmic sort of sense, I can tell you that many patients just lie awake wondering what caused this, wondering if there was something that they did to cause this, as well as worrying about things that they probably don't need to worry and not knowing where to focus their attention. In addition to this, as I said, part of our, I think, mandate is to really think about how to predict who's going to be at risk for certain health challenges, and with that, to have something medically actionable for them to do. So not just to deliver information about, for instance, a risk of Huntington's disease and say good luck with that, but really partner that with something they can do to effectively maintain their health, as well as I said, make some life plans. And I think that's been something that we've realized over time. Individuals are interested in their health. They're also interested in terms of planning for their life generally. This is a bit of a cliche, but obviously a lot of this is powered by the fact that we can sequence a genome now for a little bit less than $1,000. Actually understanding what that genome means is a big, big task, and I think we are nowhere near beginning to understand truly what that means, but at least we can now bring down the cost and the ability to get the information we need to get towards the knowledge we need. So let me give you a couple use cases in terms of how this can be quite useful, and I have to say this is a bittersweet experience for me. This is one of my patients, a lovely family, a little 9-year-old girl who came to see me who'd been seizing really from the point that she was born. With that had come, unfortunately, over time, some movement disorders, some dyskinesias, a small head, microcephaly, as well as intellectual disabilities. She was a lovely family, had no known family history of this, and her parents say what some parents say to me, which is, we got clean genes. We don't know why we're here to see you. There can't be anything from a genetic point of view, but of course there was. In this particular case, we realized with some of our advanced sequencing methods that she had actually a well-described condition due to a transporter for glucose to be able to go into her brain. She had a de novo mutation of that glucose transporter. In particular, immediately obvious to me how to treat her if her brain simply was not getting enough sugar, if she was essentially hypoglycemia or had low sugar in her brain all the time because she wasn't able to get the sugar into her brain, we simply changed fuel sources for her. Easy fix. Put her on Atkins diet, ketogenic diet, very, very high fat diet, so she's not dependent on the glucose. Instead, she can be dependent on fatty acids. And in fact, from the moment that we did that, almost instantaneously after we had the diagnosis, she has been seizure-free since then, doing beautifully in terms of her seizure control. But unfortunately, because we caught her at 9 years rather than 9 days or 9 hours, she has permanent brain damage that is irreversible at this point, which is really the tragedy of this. So I'm going to challenge us that the question for me then is, where is the right time in the life course to come up with these diagnoses, and trying to fix this burden in terms of cost about when do you do that. I'll give you the punchline in case you drift off during my talk. I think the punchline is probably not that we screen every single newborn in terms of doing a genome sequencing, but the moment someone is symptomatic, I would argue let's not waste any time. Let's get on to the diagnosis and hopefully with the treatment. This is just an example to show you. This is a series we published a couple years ago about using whole exome sequencing in this case across a wide range of conditions. And you may or may not be able to read this, but this is looking about everything from hearing loss, vision loss, congenital birth defects, autism, seizures, neurodevelopmental disorders, even cancers over here. And you can see that across this range, there's a wide variety of the yield. This is in part because when we did this series, this was oftentimes not the first line test that someone had, but the 5th or the 6th or the 7th line test that they had. So I would argue that this is the floor in terms of what our diagnostic yield is for this. If we were to use this as a first line test, depending on the condition, I would guess that we would actually increase our yield by another 20 to 30 to 40%, depending on what the condition is. With this, I think the point that I'm trying to make is that the yield is significant. This is not like a 1 in a million chance in terms of coming up with the answer. Depending on the condition, this can be a yield of at least 50%, which seems to me to be pretty good odds in terms of getting families that information. So I will be provocative again. Do we even think about, in certain cases, pushing this back even to prenatal diagnosis? So if you could know when the baby comes out the chute what it is you're going to be dealing with, that you can have time as a medical team to come up with the right treatments, and importantly, that you can engage the family in thinking about that, getting them mentally prepared for this, getting whatever they need to take care of a baby that may have special needs, I would argue that you're 3 steps ahead of the game and that babies get better care for this. So this was one of these sort of proof of concept cases. I had a pregnant lady who came to see me at 28 weeks of gestation. Her baby was hydropic, edematous, and when we looked at the heart, which is oftentimes the problem, we saw that structurally everything was fine. The echocardiogram was fine, but we could see that the beat was irregular. It wasn't always perfectly regular. Oftentimes there would be skipping of beats, at sometimes very fast heart rates, at other times slow heart rates. Again, no family history to tell us what was going on. There was no history of any cardiac problems that we had seen. So as we started talking about this was at the time for the laboratory that we were dealing with, they had never done a prenatal exome. This is now a couple years ago. This was something that was considered taboo. People, were concerned that if you did this, people would have abortions, they would terminate babies as a result of this. And I would argue it's just the opposite. This is really about giving families the confidence to know what we're taking care of and to be able to help them with that. So as we did this, I'd had patients before, pediatric patients, who had had very severe arrhythmias due to channelopathies, that once we knew what it was, we could start the right treatments, and I was concerned that this is what this baby had. And so we went in doing an exome, looking very specifically and enriched for genes that had to do with arrhythmias as we did this. When we did do this, it was very clear that the fetus had a condition called long QT, the number 2 variety of this. Incredibly important because we had actually had another child that was in the literature that had the exact same mutation, so we had a sense about what the problems were going to be. In this case, we had a lot of evidence to know that we could use propranolol, for instance, as a medication, a beta blocker that was quite effective within this. And as we did this, literally, as the baby was coming out of the chute, instantaneously we got her on the right medication. I can tell you she's now almost 2 years old, and she is beautifully thriving, has never had even an episode of syncope or fainting, has been very well tolerated, and as she's grown, all we've had to do is increase her dose of her beta blocker. And I would argue that this type of information saves you a world of heartache otherwise. It's within a healthcare system, obviously, of recognizing fetal anomalies, but with that, I would argue that we should tag team in terms of really getting to the diagnosis quickly. So for some of you who have thought about this, and in certain areas of medicine, it is a debate still within the field in terms of whether or not you need to do something on a genomic basis, something like exome or genome sequencing. Do we get as much bang for the buck in terms of doing a targeted panel of genes? I won't go into the whole debate, but I would say it depends very much on the clinical indication. For certain types of inherited cancer, for instance, inherited breast cancer, I would argue right now we do pretty well with panels. And if we think about something on very large scale, it probably makes sense to have a narrower scope. On the other hand, things that we clearly are very, very genetically heterogeneous, that may be due to even hundreds of just different genes, 80% of which we don't even know yet, it makes more sense, in my opinion, to think large and know that we're going to learn with this information and reinterpret it iteratively over time. So this is something that is still a work in progress to think about. With the panels that we have, just to give you some examples, and different laboratories have panels that get bigger and bigger and bigger, and the bigger they get, sort of the higher the yield is, but many of these have panels that approach 50% or even greater. And so again, I think it's still incumbent on us to figure out the cost benefit with this and figure out where the sweet spot is going to be. But whether it's panels, exomes, or genomes, I would argue that, again, getting to the diagnosis we need to do better on. So as we're thinking about this, I give a lot of credit to Stephen Kingsmore. He was the one who was bravest enough to think about how can you do this and do this really, really fast, basically a stat exome, a stat genome. And so at the time when he came out with his first paper on this, it was routinely taking us 6 months to get the results on this. Clearly, in terms of clinical care, I can tell you patients even forgot that we did a test when they were getting results 6 months later. So he challenged us to do this in about 48 hours. And actually, I won't say this was cost effective, because this is having someone on call to extract your DNAs, to run your sequencers, certainly not scalable, at least the way they initially did it. But with this, he did it in the neonatal intensive care unit, so thinking about critically ill newborns. This, in fact, could be done, and I would suggest that may not be that 48 hours is the sweet spot on this, but something like 7 days or within a week, I think, is very doable on scale, and something that many sites are actually now starting to study the cost effectiveness of this type of approach. So as we think about this, this is not trivial, though. The sequencing costs certainly are coming down, but it certainly is still not inexpensive. As we do this, we need to have a workforce of people, both people in terms of experts to run the machines, to run the laboratory settings, but even more experts to do the interpretation. And this is no small feat when you think about it, because we've got about 20,000 genes within our genome. I can tell you I know a lot about a lot of genes, but I don't know about all 20,000 genes. I can't be the gene expert at more than about 100 genes. And so one thing that's possible is that we may need to think about ways of being able to federate, or in fact sort of cloud or crowdsourcing this information, being able to take experts really around the world who may have expertise in different genes. And when you come up with some of these different conditions, different genes, different variants, be able to draw upon the strength of the entire community to be able to make sense of this. And this is getting better. I know one of the sessions is actually about machine learning, artificial intelligence. I can tell you that we are getting to the point now that we've got, in case, probably about 150,000 exomes around the world, to be able to share that we are learning better in terms of how to interpret genetic variants, but we are definitely not at steady state. And I'll get to that in just a second. As we think about this, as I said, one of the big challenges is for us to actually demonstrate to third-party payers that this is actually useful. And in fact, in thinking about that, I would argue that in certain clinical scenarios for certain indications, this actually saves them money. So for instance, if you're talking about critically ill newborns in the NICU, if you stay and decrease the length of stay by 1 day, you have paid essentially for the cost of that testing. And I would argue that by getting to a diagnosis faster, in fact, you will be able to demonstrate that cost effectiveness as we're doing this. As we're doing this, though, as I said, it's very clear that we don't know everything. We know of about 4,000 different genes that are associated with human disease, but that means there's 16,000 out there that we still don't know about, many of which I'm sure are associated with diseases. We just haven't figured this out yet. So one of the questions becomes, and we've certainly done this experiment, if I have individuals that I'm clear have some heritable condition, very rare symptoms, clear family history, I would argue that's my sort of truth state in terms of knowing identifying what the ground truth is, we only figure their answers out about 50% of the time when we get to these situations of undiagnosed conditions. So that tells me that there's still a gap in our knowledge, and we are still going to have to keep churning this again and again and again, learning from each other, being able to use this information, these new algorithms as we learn, to reinterpret that information over time. There's a challenge there with that, though, and if anyone can figure out the solution, come catch me at the coffee break, because I haven't entirely figured this out. But as you churn that information over and over again, who pays for that? Is this something that you pay for with the original cost of your testing? Is this a subscription service that you pay for? Do you actually return, I'll put something provocative out there, do you return this data to the patients? Do you let them figure this out? Or do you let them find someone else who will figure this out? I don't entirely know the answer to this, but it is difficult because it is not inexpensive to be able to set up systems to be able to do this. And in terms of responsibilities, ultimately, I think the patient should be able to have some say within this. We've also realized that as we've done this, and I can say I was the first to be surprised at this, that some patients don't just have one condition, they may have two. My record is patients actually having 3 independent genetic diagnoses, and I can tell you it confuses the hell out of me when some of these converge. I've had patients where one condition would say they should have macrocephaly, the other would say they should have microcephaly, and in fact they have normocephaly, and that's why it never occurred to me what these diagnoses were. And so these things are incredibly interesting, but incredibly complicated in some cases. So as we're doing this, one of the other things that the laboratories are trying to figure out, for any of you who are here representing the laboratories, is what do you report? What do you actually give back? How confident do you need to be in terms of giving that information? You don't want to confuse families, physicians, especially those who are relatively naive, when you're going out on a limb trying to suggest some new candidate gene for something. On the other hand, for patients, they really, really are desperately looking for that information sometimes. And so how do you figure out that right balance in terms of not doing any harm by putting out there something that's just completely unlikely to be the answer, but yet, on the other hand, allowing people to still keep track of things that are possibilities so that as data continues to evolve on this, that they can be the first to benefit from this information? I don't exactly know the answer to this. In some ways, I would love it if we actually had health portals out to patients where you could directly, as the laboratory, push out information to them as you became more confident of it. But right now, we have this sort of awkward situation where we've got people like doctors like me who are in the middle of all of this. And with that, there's not a direct flow of information directly back to the patient. So this is something that continues to be challenging. I will tell you the area where, in fact, it is most challenging for me right now is in the prenatal setting. Within the prenatal setting, we don't have a fully baked individual, literally, so we don't actually know that much information. We have these sort of fuzzy ultrasounds to give us some idea of what's going on, but we don't have great certainty about what the clinical sort of problems are going to be. And so you oftentimes end up going out more on a limb if you want to try and call a diagnosis, but I would argue that's oftentimes the place where you have the biggest impact in terms of being able to prepare those families. And so what information do you put out there so that maybe the neonatologist can be able to know what to look for and to be on guard for? However, many of us who are doing the most cost-effective thing right now, which is exomes and chromosome microarrays, we know we're not seeing everything. And so one of the questions often comes up about when do you go to genomes? Genomes in terms of cost right now are probably about 4 times more in terms of being able to generate the data. In terms of the analysis, enormously more. It's actually about 50 times greater in terms of the amount of data to compute on and store. So it's not trivial in terms of doing this, but there are definitely things that we miss on an exome, which is only the coding sequence, in terms of the non-coding regions, some small CNVs or copy number variants, and definitely the non-coding region. And so one of the questions is, when do we want to do this? We do give something up. More is not always better. For some of us, we're beginning to realize that, in fact, there are somatic mutations that account especially for brain disorders, birth defects as well, and that's all, as you're going to be hearing about, a depth of coverage issue, similar to what we see when we sequence tumors. And you certainly give up in terms of depth of coverage when you go to genomes versus exomes. So is there one right solution? Of course, some of us would love to have both. We'd love to have transcriptomes, exomes, genomes, give us everything, but we do have to be mindful of what that costs to be able to come to that. So as we're thinking about this, we are trying to think about also new technologies that will get us away from short read sequencing to longer read sequencing, being able to do better alignment so that these things will actually map uniquely in terms of the genome, and we'll be able to see even repetitive sequences that we may be missing at this point. And adding on top of that, as I said, transcriptomes, which will help us see some cryptic splice mutations, enhanced splice elements, and other things. So this is certainly a work in progress. Top Med, others are going to be giving us a lot of the reference data that we need, as well as the UK Biobank, and hopefully we'll come to some good reference data to make this more informative soon. But here's something that may be a little bit frightening to some of you that are down in the trenches. You may think we know what we're doing in the laboratory. We sort of do, and we sort of don't. This actually came from an NIH consortia called CSER, the Clinical Sequencing Exploratory Research Program. This was one of the working groups that I had chaired, and this was after the ACMG guidelines came out to do variant interpretation, the new guidelines. We actually took across 8 of the laboratories a standard set of about 70 variants. We gave it to each of the laboratories. We said, all we want you to do is tell us how you categorize this. 5 categories. Pathogenic, likely pathogenic, variant of uncertain significance, likely benign or benign. Should have been relatively simple, we thought. Everyone is using the same rule book now to make these decisions. We figured everyone would come to the same answer. Boy, were we wrong. On first pass, 34% of the laboratories came to the same answer. Scary part of that means, right, the majority did not agree in terms of how to categorize this. Not quite so scary in the sense that when we think about variants or categorizations that really, really matter in terms of how we clinically manage these patients, much less than that. We only had 22% discordance in terms of what we would do, but I challenge you, 1 in 5 essentially making a difference in terms of whether you'd have a mastectomy or not have a mastectomy based on a BRCA mutation. That's big stuff as far as I'm concerned. So we weren't feeling really great about that. On the other hand, there is a path forward. We got everyone together, started sort of comparing notes in terms of why they were categorizing things they were, looking at the evidence they were using, comparing notes. We got up to 71% in terms of concordance between the laboratories, and we knocked this down in terms of disagreement that were clinically meaningful down to 5%. On the other hand, that still means even with people talking to each other, using the same evidence, using the same rule books, we don't always agree. There's still a matter of judgment that goes into this, and there are circumstances that I can say I've seen from laboratories as recently as last week where something went from clearly pathogenic all the way down to likely benign. And to me, that's a big change in terms of the disagreements. Part of this is, and I will warn you, some of you know about this, a lot of this is the reference databases. As we get more and more reference database from normal individuals, and I will warn you, especially about underrepresented minorities, that is where we tend to make the biggest number of mistakes. That is that for individuals that are not Caucasian, of European ancestry, we simply don't know about a lot of the normal variation, and we desperately need to have more of that information so that we can correctly interpret that information for our patients. How do we get there? It's all about data sharing. It's all a numbers game in terms of doing this. We can talk about what we've got in terms of 1,000 genomes. 1,000 genomes ain't nothing compared to what we need. We are going to need hundreds of thousands in terms of putting this information together. And as we do this, I do think we need to think about in terms of making it consent informed to be able to do this, but truly respecting our participants as we're trying to share these data, both in terms of the raw data as well as some of the curated data as well. And these are just some examples in terms of some of the data sharing that are out there. Global Alliance being one of the biggest in terms of putting these data together. So as we do this, I just want to briefly tell you a story of one of my patients. It was a patient who actually came to me, an African-American woman with bilateral breast cancer. I was quite stunned when she told me that she had had genetic testing about 5 years before and her results were normal. We went back and we did a panel of sort of more genes that we thought would be better at this point, and I was stunned when she came back with a BRCA2 mutation, and I said, how in the world did that happen? You told me your results were normal. Show me a copy of your report. She couldn't find it, so I did some digging and went back and found out that, in fact, her first test report showed that she had a BRCA2 variant of uncertain significance. At the time, it was unknown what it meant. Over time, it had actually been reclassified by the laboratory, and I give them a lot of credit for this, reclassified to being pathogenic. Unfortunately, that result was sent to her doctor. Her doctor changed hospitals, moved, never got that report, and as a result, my patient never got that report. There was a chain, a broken link in the chain. She never got that information, and I would argue if she had known that she actually had a BRCA2 mutation, she would have done things differently, at the very least in terms of her health surveillance. And unfortunately, she now has metastatic disease and probably isn't going to make it much longer. That to me just doesn't seem fair from her point of view. But who's responsible for that? From a legal point of view, from a health systems point of view, who's responsible? The laboratory did their job. Her doctor did his job. He just happened to move. The institution really didn't know any of this was going on. And the patient really wasn't equipped, to be honest, with this information. She thought she had a normal result to start with, so she wasn't being proactive. She wasn't sort of looking out for this. And again, if we think about this, if there is an obligation somehow to reinterpret this information over time, whose responsibility is that? Who pays for it? Who's legally responsible? How do we set up a system to do this? So again, I'll challenge you. I would argue that we need to have more engagement of the patients themselves. We need to keep them connected. They are part of the solution to this, but we have to figure out ways of being able to do this in a simple enough way for them to navigate the system, not overwhelm them, not freak them out about some of these things, and be able to use this information because we are still in this process of iteratively reinterpreting over time. Let me tell you about a happy story, though, to hopefully end things up. So some of you may or may not know, but the #1 genetic cause of death in children, which I hope we will change soon, is a condition called spinal muscular atrophy. Looking around this room, there are probably 3 of us or so who are carriers for this condition. It's an autosomal recessive disease. It has the convenience for me as a geneticist of almost everyone having the exact same mutation, so it's relatively easy to screen for. And I won't go through the beautiful molecular biology, but I will say that there is now an FDA-approved medication, which was my Christmas present this last year, to be able to treat spinal muscular atrophy. And so we knew about this, and I had sort of had this idea because I knew about the clinical trials going on that we might have the opportunity to even do population-based screening. Why is population-based screening important for this? Well, if you don't actually get identified and treated, this is a degenerative course, you get worse over time. You actually have atrophy of your motor neurons, and this is what eventually kills you in terms of respiratory support. Once you start going downhill, I'm not convinced you can go back up. So it is a one-way street, I think, probably to a certain extent, and so we need to be able to get in and start treatment, I would argue, even before a child is symptomatic, to be able to maintain their best chance at health. So in doing so, we thought about doing this now on a population-wide basis. Don't wait for a family history of this condition because it's recessive. It pops up out of the blue. We see it with fair frequency in the population, about 1 in 10,000, and we could bring down the cost of screening. I can actually revise this to now 10 cents per baby. So we can do this on scale to be able to do it. So we started this out in New York State. Go ahead and play the video. We identified this baby in January of 2016. We started her in the clinical trial of the Nurture trial with nusinersen. These are her first steps, actually. I can tell you she's now about 19 months old now. And she was treated from 15 days of life. She is thriving. She would have been literally in a coffin 6 feet under at this age, but she has had normal development, normal motor milestones, never had a respiratory problem, never been hospitalized, normal growth trajectory. You could not pick her out of a crowd right now. And this is the opportunity that we have. Some of you may have seen the New England Journal paper that just came out. Gene therapy is now the next thing that we're doing for SMA. Hopefully at some point a one-and-done treatment, so to be able to take these children and give them potentially normal lives afterwards. So in doing that, I think it's now think about how do you do this on scale? How do you do it cost effectively? How do you now bring this to the point of maintaining health? This slide, which I won't go into a lot of detail, but is just to make the point that I think we are now getting to the point in adults about thinking about, if you were thinking about a newborn screen for babies, could we think about a newborn or rather an adult health screen? The place where I think we're most likely to start this is with heritable cancers. You can now, depending on how you bend the cost curve, certainly do this for BRCA1 and 2 and the Lynch syndrome genes, I would argue. This is a study just demonstrating in a Jewish community very clearly how cost effective it is to be able to do this. Color, actually, I'm not, again, selling for Color or any other company here. Color had a special last month in October for Breast Cancer Awareness Month, $99. You could be able to get your entire hereditary cancer gene panel. If you can get the cost down that low, then you can start to demonstrate in terms of insurance and third-party payers, this is even more cost-effective than mammograms. So to be able to do this, if you can do this reliably on scale with the correct interpretation, I think you can now start thinking about how you do this with population health. So I would argue, though, that we are just at the beginning of this. If you take hereditary cancers, we certainly have historically been worried about high penetrant genes, genes that have huge impact in terms of health. Clearly, they're important, but they only account for most cancers, 5 to at most 10% of the cancers that we see. What's all the rest of it? There's a lot of other heritable stuff that we haven't really even begun to look at, moderate risk genes, and even polygenic risk scores, which are now starting to be possible to do, at least for the common cancers. We're going to have to figure out the models in terms of computationally putting all of those risk factors together with epidemiological factors to then spit out for a patient, what is your life course, what is your life risk of this, and then near term, what is your risk in the next 2 years, the next 5 years, be able to plan out and ideally think about if, how, and when to intervene. So as we're thinking about this, I hope I've convinced you there's some real opportunities. I wouldn't say it's universally across all clinical areas, all life stages, but I do think there's some opportunities. The costs have come down now that it's possible to do some of these. I do think paired with this, we now need to start thinking about therapeutically, what can we do? It's getting beyond the diagnosis and thinking now about the therapeutics, but setting up systems that give us the flexibility of still being able to build and learn as we do this, and importantly, gathering collectively as a community, because it's going to take everyone, the evidence that we need to actually demonstrate both the clinical utility and the cost effectiveness. So I thank you, and just to think, I've got a great team of people that I get the pleasure of being able to work with, and I just put my email up here if anyone has suggestions afterwards.